So let's discuss bone marrow failure anemia. Bone marrow failure classical example is aplastic anemia. There are other conditions which can cause bone marrow failure as well. Now, what are the features of bone marrow failure anemia? The classical features of anemia like weakness, fatigue, shortness of breath, lightheadedness, dizziness, etc. may be present. There is evidence of recurrent infections which may be bacterial or fungal because there is neutropenia, and then patient may also bleed from mucous membranes and skin because of thrombocytopenia. The features of disease causing anemia or pancytopenia may be present. For example, disseminated malignancy with metastatic deposits in the bone marrow. This replace the bone marrow and result in bone marrow failure. So the features of this disease may be present. When you see the peripheral film, there's bicytopenia or there's pancytopenia, and there are very low or no retics. This is classical in bone marrow failure. Now, this pancytopenia can be produced by conditions other than bone marrow failure. For example, peripheral pancytopenia may be result of cytotoxic chemotherapy, hypersplenism, infections like tuberculosis, HIV, leishmaniasis, brucellosis, CMV, parvovirus, B19, and then ionizing radiation can do that. Megaloblastic anemia is one. Drugs, and finally, autoimmune disorders like SLE, they can cause it. And then we can have a central pancytopenia. Aplastic anemia is the classical example. And then we can have acute leukemia. There may be chronic idiopathic myelofibrosis. There may be infiltrative disorders like lymphoma, leukemia, myeloma, hairy cell leukemia, or as I said, disseminated malignancy. They all may replace the bone marrow and produce central pancytopenia. Myelodysplasia is another example of producing pancytopenia. And then what are the causes of aplastic anemia? Classical is autoimmune idiopathic aplastic anemia. It may be part of SLE as well. Chemotherapy, radiotherapy can produce aplastic anemia. Dyskeratosis congenita and Fanconi syndrome are another chromosomal abnormalities which can produce aplastic anemia. Malignant T cell large granular lymphocytic leukemia is one that can cause aplastic anemia. Drugs like chlorphenicol, gold salt, sulfonamides, quinacrine, phenytoin, carbamazepine, tolbutamide, they can produce aplastic anemia. Infections like parvovirus B19, hepatitis viruses, echoviruses, CMV, they can also produce aplastic anemia. Then paroxysmal nocturnal hemoglobinuria is associated with aplastic anemia. Pregnancy can be one reason. Patient may develop aplastic anemia during pregnancy, and then certain toxin like benzene, toluene, and insecticide, basically the chemicals which contain benzene ring, they can produce aplastic anemia. Now, when you get a patient with whom you suspect there is aplastic anemia, get CBC and retics and immature platelet fractions. But retics are low, as are the immature platelet fractions, they are low. Peripheral film generally is normocytic, normochromic. There may be some macrocytosis. Otherwise, this is generally normocytic, normochromic. Bone marrow examination may reveal hypocellular, acellular marrow. Sometimes if you aspirate, the aspiration site may be containing pockets of hypercellular marrow, which are trying to compensate. So a core biopsy or refined biopsy may be more useful. Abdominal ultrasound, chest X-ray, CT scan to rule out other conditions which may be causing bone marrow replacement, autoimmune screen, flow cytometry and FLAIR testing for PNH, rule out suspected infections, pregnancy, and go for chromosomal study if there are abnormal chromosomes or fragile chromosome which can result in aplastic anemia. Identify, avoid, and treat the underlying cause. So start the treatment. Identify and avoid the underlying cause and treat if possible. Patients may require supportive care, which is transfusion and treatment of infections very aggressively. Definitive treatment, many algorithms are available. We just go for a simplified algorithm that what you do when you get a patient of aplastic anemia. So with a patient of aplastic anemia, look, if the patient is eligible for immunosuppressive therapy or hematopoietic stem cell transplantation, comorbidities are absent, willingness of patient, check all these. If they are not present, go for the supportive care, that is transfusions and control of infection. If patient is eligible for stem cell transplantation or immunosuppressive treatment, no comorbidities are present, patient is willing, then if patient is less than 50 years with HLA match, hematopoietic stem cell donor available, hematopoietic stem cell transplantation is the best option. But if the patient is not a candidate, patient has not available donor, see if it is severe aplastic anemia or very severe aplastic anemia. You assess aplastic anemia by seeing the bone marrow cellularity if it is less than 25%, and if the neutrophil count is less than 0.5, the platelet is less than 20 and retics are less than 20. This is severe aplastic anemia. If the neutrophil count is less than 0.2 and platelets less than 20 and retics less than 20, this is very severe aplastic anemia. Or if the patient has severe infections or the patient is older than 50 years in which transplantation is not really a very good choice, then go for antithymocyte globulin and cyclosporin. If the patient has moderate aplastic anemia, the neutrophil count is more than 0.5 and there are no severe infections, try cyclosporin with androgens. If the patient is not responding but still eligible for immunosuppressive therapy, then go for ATG and this cyclosporin. If the patient is not eligible for immunosuppressive therapy, best supportive care should be provided. So this is how we proceed with patients who got aplastic anemia. And then there are other problems. The patient with aplastic anemia after transplantation may get the graft versus host disease. So that is a different topic. We'll discuss it in a different video.